It takes a while when you give it to
Warm up first.
Oh, no, it's never quite like
You go home.
I like to sit right here.
Carol and Lance. Let me get down inside. He's been trying to get IT. I'm having trouble getting this thing. You did that? I started on there. Yeah, I can.
My cousin's turned $1,000 to his brother. He said I had to.
You want to shut the door and pull it?
He tells me I don't know how to do it.
All right. Good afternoon.
Good afternoon.
We got a lot to do today. I got some important announcements, and it's not for everybody, but I still got to tell them, okay? On December the 3rd, after it starts, December the 1st, there's an IPF summit in Chicago, interstitial or idiopathic pulmonary fibrosis. It's a big deal. It's put on by the Pulmonary Fibrosis Foundation. They asked, I don't know where they found my name, but they asked us to be a host on Saturday. They're going to have 8 or 10 speakers, and they're going to broadcast this thing I can't get to work on this screen. And they invited anybody who wants to come to it. It's free with your donations. Breathmatters is going to buy you breakfast, lunch, and snacks. And I got the schedule. So if you've got pulmonary fibrosis and you're interested, please. I'll hand them out to you. We're going to start. There she is. Hello, young lady.
Happy birthday.
Our speaker is Bernadette's guest. She is responsible for the good and the bad. Yeah, she's short girl. All right. You know how we go around the room. You know how we go around the room, so everybody gets to know a little bit about each other. And we got to introduce ourselves, tell us something we don't know about you, or you have a choice of giving us a secret that you feel like helps you better with your lung disease that may help somebody else. Okay? We'll go around the room. We want to move on to speak to her. That's how you handle her.
I have no idea.
All right, so we're going to start here with this gentleman.
My name is Richard, Dick, and I've been at this for about 2 years now. Idiopathic, I'm not lucky like you, COPD.
No, it's not. Okay.
My name's Darren Ragnar, he's my father-in-law, and I'm just here for the day.
Good. Keep it good company, right?
Yeah.
I'm married in Richmond, I've got COPD, been here about a year.
Joan Hammer, I have COPD. I've been here for over 2 years.
I'm Ray Lance, and I've got COPD. I guess I've been coming to these meetings for about 5 or 6 months. I'm finishing up 6 weeks worth of rehab upstairs.
Just 6 weeks?
I've been going 6 weeks, and I thoroughly enjoy it. I'm getting a lot out of it. I get to spend time with my friend Bechard over there. We talk football. Doesn't get any better than that. Yeah.
The fellow upstairs named Mr. Woody. I don't know. He and I have been coming about 7 years.
Yeah, it's very
And
good.
they tell me I got to go the rest of my life. Wish I was finished.
Hi, I'm still on school site. I have allergies, asthma, reactive airway disease. And the thing that I want to share is we had our 50th high school reunion.
Oh,
We had a ball. Yes.
so that means you graduated when? What did you?
61.
Okay.
Now you can think how old we are.
I graduated in 64.
Yeah, younger.
I'm Joan Loud, and I'm Phyllis's friend, and that's my husband, Ray, and I'm here for knowledge and trying to keep it straight on the narrow path.
I'm sure it's.
It is.
I'm Joe Bresting, and the latest diagnosis is that I may have acid reflux. That's why I'm interested.
Okay, that's all right.
I'm Boshor, and I'm here in support of my wife. She couldn't make it today, so she asked me to give her report.
Horse has some fixes today. He's wants to auction off all-wheel sell for as little as $5. And the money goes to us as a let's get this girl back here.
Hi, I'm Rachel. Is this on camera right now? I'm Rachel and Lynn here. I'm hungry right now. And I brought the food and I'm really happy to be here.
And thank you for bringing it. I'm going to discuss the other
Oh,
part.
I'm still with him.
You're still with me? Make a note of that.
Now,
You know what he's doing? This fellow's passing out free books from the library. They don't want them, but they think you do want them. And if you choose not to take the book, we'll send it upstairs to the Chippenham Library. Buddy.
Buddy Kane, COPD. I spend long hours with my cat.
Cat's name's Daisy. And on the bicycle with it too? Howard.
I'm Howard, and I thought I had empathy. Also, acid reflux disease. It's a topic I'm quite interested in.
You can almost guess who doesn't have it.
But I'm prone to getting pneumonia, and every time I've gotten pneumonia, I've had acid reflux. Every time I've had acid reflux, I haven't gotten pneumonia.
You hold the record back from pneumonia too, don't you?
I've had pneumonia 20 times in the last 4 years.
And he's still with
And I'm getting tired of it.
us. You live in Calabash.
Yeah. I live in Belgium.
I'm Dolores. I have pulmonary hypertension, pulmonary fibrosis, and bronchiolitis.
how many is here?
I'm Eleanor Fisher,
Joan Hammer.
and I have COPD, pulmonary fibrosis,
Oh,
acid reflux, God knows what else. I'm glad to be here.
Let's keep coming back to this now, please.
I'm Doris O'Connor. I have COPD. I'm a new member here. I'm 73 years old, and I'm glad to say I'm going to be a grandmother for the first time with twins.
I'm Sam Counts. I have COPD, COL, and acid reflux. And unfortunately, I've been married 48 years to her.
If it is like my wife, I wouldn't be here without my wife. My mom still tells me that I'd be in a ditch somewhere.
I'm Mary Morgan. I have COPD, and I just keep coming and learning. Coming and learning.
Virginia Miller, COPD, and I'm looking forward to the talk today because I'm...
You okay? It's your,
Harold Brockton, I think I just beginning to have COPD. I've had everything else in there.
wait, is that old?
I'm 85 years old. Yeah, and
Yeah, 85?
I was 85 in March, working in Bushor. Breathing better with the shuffle that's other than that, I'm real healthy and taking care of Virginia Miller. We're looking at her to see if she don't fall or anything while we're going there in this place. We've been together 30-some
That's what I was gonna ask you, I've been together over 35 years.
30-some years now. I got married.
Oh, today?
Well, he said we go together and see her birthday. She does half, and when I say,
When she gets that straight, you're gonna marry her. All right.
On the mix-up, I'm still there. And my grandson ran the marathon in the 20-hour under, and he was 8th.
My name is John Kirsten. I just stopped by to get something to eat.
And I have been diagnosed with alcohol 10 years ago. Janet Pinson and MCV recommended that my husband and I come.
You're taking some of the alcohol, right?
Oh, yeah.
Alkaline?
You want to explain that real quick?
L1 antitrypsin deficiency is a lack of an enzyme that helps protect the lung from the cells that fight infection. And as a result, you get accelerated breakdown of the lung tissue. And it's a classic form of COPD. It's not very common.
But it's controlled by a pill. We did here, October 2 years ago, we had people coming from Baxter Pharmaceutical and testing. Anybody want to be tested? We must have had 90 people there. They never saw half of them again. But they came for the free test. And the speaker we had in October this year, Jim Farrell, with the Center for Disease Control. And he has it too.
Well, it is a simple blood test.
That's right.
That diagnoses it in case anybody.
Exactly right.
And it's also passed on within the family, so usually you do counseling as well, and other people in the family should be tested.
Jack Reed, I'm here with my wife.
Thank you for coming, Mr. Reed.
I'm Deb Easton, I have allergies, and I had a wonderful lunch with David Sanders last Friday with a couple of other gal friends, and he is now in a wheelchair. Now, but he's mostly.
While we're here, let's start talking about David. Those of you that don't know it, if you look at these business cards, we're still hanging out.
Yeah.
David was my co-facilitator. Started this thing 6 years ago this month. He too had pulmonary fibrosis. He's in his late 70s now, and the pulmonary fibrosis is finally got him. So he hasn't been to a meeting. This will be the 4th meeting he's missed. I asked him not to resign officially until our Christmas meeting. We'll talk about that in a minute. He thought he would come into this one. I offered to bring him. I took him to the doctor this past Tuesday. I took him the month before. He's not doing it just like us. And it's sad. All right. All right, Jeff.
I'm Mary Jo Adams, and I have emphysema, asthma, reflux, and among a few other boring things that we need to talk about.
I'm Sharon Peppel. I'm on the board of Breathmatters.
Yes.
Russell. And I have pulmonary fibrosis, which has more or less leveled out. I'm being treated at Duke, and there's a guru down there who
got me stabilized, which is pretty amazing. But at any time, that could change. I also have acid reflux. But I read something in the paper that might be of interest. The doctor may know about it. Flaxseed. And you make tea out of flax seeds. And someone had written in to that pharmacy column and said that it's absolutely worked wonders. So I thought it's worth a try. Yep.
It's always worth a try.
It's always worth a try. Flaxseed tea, here we go.
I wonder if the flaxseed pill. What if that flaxseed oil pill would do the same thing?
No. Gotta be the seed.
Has to be the
Gotta
tea.
be the seed. You read it? Anybody
Yes.
else read the article?
I read it, but I forgot what I read now that I read it. I'll say it.
Yeah. I have the article. Pardon?
How do you make tea from seeds?
You boil water, you put the seeds in your cup. I have a little strainer like you would use with tea.
So you just let the water run through the seeds?
Let it just sit there and then drink it whenever you feel like it. It doesn't have a great taste. Yeah. It has a little nutty flavor.
Oh, okay.
But nothing horrible. Now, you can eat the seeds, but I'd put them in my cereal or in a brownie or something. The seeds.
That'd be different for a brand. And it's for what disease?
Acid reflux.
Acid reflux, now, I heard you ask a question. Yes,
That
ma'am.
doctor's gotta go back to school. I'm not sure of that tip.
Anything that works, I say go with it.
That's right, I tell you. My name is Helen Grice. I have a disease called lymphangioliomyomatosis. Quite rare.
Lamb's disease.
Lamb.
Yes.
We have one of our people that's waiting for a transplant to happen.
Oh, really? Okay.
I mean, you can see
Marge Leary.
Yeah, okay.
Yeah, I know Marge. I've just met Marge a couple of weeks ago at a LAM event. Yeah. So my pulmonologist recommended I come to rehab and saw the sign up there, so I thought I'd come here. And I recognise some of the faces from upstairs.
My name is Susan Gregory, and this is my first meeting. And I have COPD and acid reflux. And through the grapevine, I've heard good things about this group, so I'm so glad I'm joining you.
Welcome.
Susan, are you Ronnie Pitt's friend?
No.
Okay, she told me to look for a white-haired Susan today.
Oh.
Center Stage, yes.
Center Stage, yes, but her name's Linda Davis.
Oh, okay, well, Ronnie is the one that comes here with her father-in-law.
Oh, okay.
I'm the right person.
Yes, yes.
I'm Jean Stagg. I have asthma and acid reflux, plus I'm a caretaker for my husband who has pulmonary fibrosis, and at this time he's in the emergency room.
Oh my God.
And I wanted, he was resting, so I wanted to come to the meeting.
I'm Bernie Anthony, retired respiratory therapist, and I have interstitial lung disease, pulmonary fibrosis, and
I'm Don Baines. One quick note, a little bit later, Russell's going to talk about the Christmas party. We'll have a list going around for food. Also, I'll have a list going around a little bit later. Make sure that you get on this list so that we know to contact you or whatever.
What kind of list is it?
This is the attendance list.
The attendance.
Okay.
All right. And we'll send that around. You should have your box. If you don't, if it's your first time that you're here, in the back of it, on the third page, please fill in the information so we can contact you about the next meeting or any information that does come up.
And email. Not everybody does email, and that's fine. My mom, a lot of people don't do it. But it's difficult to make sure we contact everybody when the email is not involved. That's just what it is. But you left off gorgeous, didn't you?
Yeah, because.
Or is it curious? George.
George behind
You already saw me walking around and getting the books out, right? I'm the book guy. And
And I'm here for acid reflux, though.
Okay, how's your bride?
The books are courtesy of the Chesterfield County Library. The writing is not quite large, but there's plenty of distance between the lines, so it's easy to read. It's something different this time around. So, glad to be here. Thank you.
And your bride?
Put a donation into the.
How's your bride?
How's my bride? She's going to pick me up on the way to another doctor's appointment.
Please tell her we asked. Yes,
Well,
ma'am.
one more thing.
Donation in here.
Since acid reflux is a thing, I had acid reflux up to about a year ago,
Just leave it on the table.
and I lost some weight, lost about 20 pounds, and I don't eat within 3 hours of going to bed. It's just a no-no in my house. I don't eat anything. And that has helped me more than anything else. I'm off my pills. I don't take pills anymore, and it really has helped me. So just a tip.
I'm all done, he just said everything.
One more thing, right? The books, take them home. Okay? I don't want to bring it back to the library. Actually, we're going to take whatever's left here and we donate them to the hospital. Okay? But if you have any interest in any of them, grab it and take it home. Okay?
You're most generous to do this. I know it takes time, and you bring a present, and we really appreciate it. Anything else, Don? I'm sorry I interrupted you.
I'm Judy Bain, and I don't have a lung problem, but I
And she supports her husband and works hard with him. You support your husband and work very hard for Breathmatters with him. Thank you.
I'm Gene Calvin, I'm here to support my wife Judy, who has a lung problem. And I just celebrated my 53rd class reunion last weekend.
I'm Judy Calvin. In addition to lung condition, I have acid reflux also. I've been coming here about 3-4 years now, and I always leave knowing something I learned during the session.
My name is Marge Jameson, and I have bronchiectasis. This is my first time.
Esther Patterson, support woman for my husband.
I'm Pat Patterson, 84 years old, and I've got pulmonary fibrosis. And I'm on number 5. I move about, I have to go to 6, but I wonder what I'm going to do when I get to 10.
Well, you have to go through the oxygenator, that's all. They make them. Liquid Air has one that goes, I think, to 12 or 15. And this girl over here got one for David. When David got steps, he has to go to 11. Yes.
Beverly went and have COPD.
Beverly's one of our star people. Oh, Lord. She does so much.
I get in a lot of trouble, I know that.
Keeps a low profile. She's like, we have to do her like the teachers used to do me. They just would come by and I'd be yakking my mother, and it just kind of touched me. And I knew that meant.
Hush up.
Yvonne?
I'm Yvonne Bellamy Arvin. I have COPD, and this is not new, but I tell you, if you don't go to rehab upstairs, you should go. It probably is the one thing that could help you as much as anything else. 2 years ago when I started, I was able to do 6 minutes on the treadmill. Now I'm up to 30. And actually can chase around behind my 3 grandchildren and not totally fall out on the floor. So, oh, excuse me, and I'm on the board of Breathmatters.
Hi, I'm Dexter Raines. I was diagnosed with idiopathic pulmonary fibrosis last year. Was listed for a lung transplant the end of April. Got a new lung 12th of June. So I'm 5 months into this. And a secret, you don't want to wear a ball cap and this mask into the bank. fantastic.
Fantastic.
I go there for a hangout.
I'm so pleased with you.
Oh, they are fantastic. I can't say enough about it. You know, I saw 25 doctors. Of course, it's a teaching hospital. By 11 a.m. in the morning, I started keeping track. I was only in there 8 days.
Wow, that's amazing.
I would say on average 25 doctors a day. But they were just in. I just graduated. I don't have to go over there except once a month now.
Wow, you're doing fantastic.
Doing well.
I can breathe. I was on oxygen 24/7 up
And you had
until
pulmonary fibrosis.
I had pulmonary fibrosis, and the day after they woke me up in intensive care, I was operated on the 14th, a year, 5 months ago today. They said, "You want oxygen?" I said, "No." I got up and started walking.
Wow.
So it's, you know, a gift of God.
Boy,
I do want to. Everybody asks, you know, do you know if you've got who you got the lung from? And I said, I don't know, but I think it's a female lung because I love singing in the shower now. and I've been kicked out of Victoria's Secret twice.
Between Jamaica and Victoria's Secret, you're not doing good job.
No, I did last week. The gentleman, I got a right lung, and the gentleman that got the left lung from the same donor, he and I met last Thursday.
Oh.
And you really don't know what to say. We just kind of sit and stared at each other.
Gosh.
And, of course, my wife knew his daughter, and they sit there and just yakky, yakky, yak. We just kind of, Mr. Evans, I just kind of sit and stared at him. Because now we're lung brothers.
Right.
Did you get double or
Came
second?
from the same
Oh, I just got
person.
I got the right lung, and just Mr. Evans got the left lung.
Wow.
Mr. Robinson.
Oh, I'm Bill Robinson. I have COPD. Been coming here a while. Been married about 42 years. I don't know why it's been that long, but for you gentlemen that have not reached it yet, the only thing you do when she said jump is how high.
You want me?
Absolutely.
Oh, I'm Amanda Wells. I have COPD emphysema, and I've lost 50 pounds. I have.
You lost how many?
50.
Which one?
Wow. Well, she dumped it.
Wow.
And I've become very active, and I have acid reflux, and I totally agree that, you know, 3 hours before you go to bed, you don't need to eat, and the weight loss has helped me tremendously.
Can I ask real quick, what did you do? Did you go on a special diet?
I basically follow a healthy eating plan and working out. I have a gym in my home, and I tap dance.
Oh, okay.
Well, it's pretty much everything you need. I have the treadmill and the weights, and we have everything, all kinds of, you know, whatever.
I'm Jane Griffith, and I am here just as a voice for IPF. My husband had IPF, and when he was diagnosed March of '07, Dr. Norella, the pulmonologist, said, this is a terminal disease, and you have 3 to 6 months. So I began trying to research and find out everything I could about it, and was so grateful that he was able to do some pulmonary rehabilitation. But he had already lost 30% of his lungs when he was diagnosed. And so what I'm interested in is surveying people with IPF to see what their symptoms were that took them to the pulmonologist.
All right, and she signed up for this program we're having December the 3rd. And I met Ray, the Merlot man.
Anyway, so I complained to the doctor recently that I was tired all the time. And my sister reminded me that I was that both my parents had low thyroid. And so I ought to have yours checked. And so I did. But and they also checked to see if I was pre-diabetic. Both of those were negative.
Good. Well, we haven't seen you. I've asked about you. How are you?
Teresa.
Fine, thank you.
Right after she.
Need a little printed on. I'm Teresa, and I want to tell everybody that there's also a seminar going on in Crystal City on the 2nd and 3rd of December. It's going to have a lot of exhibitors. It's all free to COPDers. So if you want more information, see Russell. I'll have him Xerox a couple of these. Thank you.
Is that something I'll put on the web? Okay. The web guy, nobody's, he kind of lays low. This gentleman back here handles our web. His name is Eric.
Yes, she has to do the post. Okay.
Did you get these other two ladies? These two
No, we
ladies?
didn't get the two ladies.
Okay, hurry up, hurry up. I'm Mary Mitchell. I have atrial fib, pulmonary hypertension, and cannot sing the praises of the research pulmonary team and MCD.
Well, thank you.
I'm Marie Quinn.
All right. And we got a question. Yes, ma'am?
Yeah.
I've already had my chance to talk, but there's a lady here that called me up on the phone to remind me about the meeting today. Is she
No,
here?
Ellen official.
Is she here? I don't know who she was, but she was a doll, okay? And I really appreciate getting a call.
Dee Roseman has asked that she not do it anymore, along with Dee. And her husband. You know, from the world. And Judy Cow has taken over Dee's job of calling, and we thank you for it.
Yeah.
Now I'm going to pass around a Christmas list. And what we thought we would do, you know, we ask for money every month, and I'm sorry we have to ask for money. But we appreciate what you do, we really do. So, you know, for Christmas we're going to have a kind of covered dish. We're going to have some money one more time for the year. We're going to have John Bird is a volunteer at United Network of Organ Sharing Units. He's a ventriloquist. He's a fabulous ventriloquist. His brother-in-law got a lung transplant 16 or 17 years ago, so he's the exception. We don't generally live that long. And because of some of the meds we take, he ended up losing the kidney over time. And so he gave his kidney to his brother 8 years ago. So he's real active in all this. And he's just a fabulous one. I've seen him take a milk glass vase and talk to somebody down in a milk glass vase. Trying to coax him out, and the fellow tells him he needs help. And so he puts a stick down there, and the man grabs the stick, but he won't come out still. And so he holds the stick and he holds the bottle. That's all. He's just going to love him. We never play. And we're going to talk about our meetings coming up for the coming year. January we have Dr. Paul Fairman. We'll talk about pulmonary fibrosis. And Tuesday, February, I think Chris Bechard is going to talk about pulmonary rehab. Pulmonary rehab does more for us than anything else we can do, no matter what disease you got. In March, we have Heidi from UVA, but I don't know Heidi's last name.
Flanagan.
And I don't know her topic, but Sharon has made this arrangement. We'll get it all right. She's an important person in the transplant process, so that's the important thing.
She's the counselor. She's the one the nurse counselor. Dexter can probably tell you more about what she actually does.
That's all the progress we got so far. Well, it was time to have Dr. Moses again from the VA. You know what he's going to talk about? How important exercise is in the project. Well, it's important. So,
Exercise is one of the best things. I had cancer, and I got down to 130 I mean, I got in on 32 pounds. I weighed 194. I had got 132 pounds. And I couldn't walk on it. So chemotherapy, so I told the lady, she kept telling me, keep on chemotherapy. I stopped. We started with almost a half a month. Then I started 2 half, 3 half. 1 mile, 2 miles,
Exactly.
3 miles. Walk.
So important. So
Then it's all, I went and got everything cleared, and all cleared.
still didn't marry. Still didn't marry. When we meet in December, for Christmas, we're going to have our board of directors meeting for the fourth quarter. Okay, we'll just talk about how much money we got, what we're trying to do, things like that. And we want to talk about what we want to do next year. I've done the first 3 meetings. Y'all need to tell me what you want to do the last 9 meetings. Okay?
What's the date on that again? The same.
Second Monday of the month.
Second Monday of the month,
Okay?
you're staying with
Now,
that, right?
I had a list I made around here for Dr. Bechard. I can't find it. Does everybody see that? On one side, talk about vaccines. On one side has vaccines. All right, Dr. Bechard grew up in Kodak place. Who knows what Kodak is? Rochester, New York.
Yeah, Rochester.
New York. And he went to school at City Binghamton, Queen Med at Syracuse, the big arts country. And then he came back to Virginia. He was
Never going back north.
he did a scholarship here, which is the final pulmonary critical care, and what was the other one you did? Internships and
Chief residency, fellowship. I just found out any reason to stay in Richmond I came up with.
he must have met his wife.
We met in the ICU. She's a nurse in
She was from Virginia, right?
Massachusetts.
I came from Rhode Island.
The 2 Yankees met in Richmond.
They married and they had 2 daughters, one of which is a nurse. Is she a nurse?
Yeah.
Okay. She got a degree at UVA. His wife's a nurse. His daughter at Clemson was on the swim team and studied psychology.
Oh, nice.
Trying to figure me
His
out.
hobbies are 2 of his hobbies are my hobbies: photography and digging in the dirt. 4th one is sci-fi. He likes to read about sci-fi. He is chief of the pulmonary department at the VA. We're very fortunate to have him. And as you know, he's got a tough time. Somebody wanted to know, could we have a show of hands who does not have pulmonary acid reflux?
I do not have it.
I had a slight
You know what it is? It tastes like vomit. Who's that now? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, the other 30 people here?
I think I'm starting to get hard. Well, thank you very much. I'd like to thank Bernadette for asking me to come here and talk to you. As far as some secrets to give you, number 1, I can't agree with what's been said here before. The most important thing for you guys is rehab. Okay, you need to stay physically fit. The heart patients don't seem to have any problem getting rehab. As soon as they get out of their MI, they go right back into rehab. But the lung patients have been much harder to get people into that type of thing. But with rehab, you'll get better functional status, you'll have fewer exacerbations, and you'll feel much better. So it's very important. The last thing you want to do is give up, sit in a chair, and just then let the world pass you by. You need to stay active. The second secret, you guys already know, this group is a fantastic resource. Being able to meet and talk to other people that have the same symptoms, the same suffering, the same type of concern is very helpful for you getting through your day-to-day activities. Many of the important lessons about your illness, you're not going to learn from people who come here to lecture. It's going to be from the people who are sitting next to you, because they've lived through it, they've experienced, they've tied flax teeth, Okay? I don't know anything about flax tea, I'll tell you right up front, okay? It is true, though, that tea itself is very good for people with asthma and with COPD. Tea has theobromine, which is like aminophylline, so it helps open up your airways. So I don't know if flax has something else that works with the esophagus to help with that. One last secret, I have 8 cats. I know somebody else here had a cat. So
I have 5.
Everybody says, how as a lung doctor can you have 8 cats?
I know, I couldn't even go over.
No dogs? But it's one thing that's kind of helped us get through a lot of things. We tend to travel a lot, so we can't use, these dogs are very difficult to have if you travel. Cats. We live on a 10-acre area, so we just let them go out in the woods and they take care of themselves. Well, Bernadette had asked me to come up with a topic that may be a little bit different, or one that you probably hadn't gone through before. And I don't claim to be an expert in esophageal reflux. Okay? I've done some work with it, but I do understand a lot of the interactions between esophageal reflux and the lung, and that's really what we're going to talk about today. Russell asked me to keep it fairly informal. I don't have any presentation, no pretty pictures. And to be honest with you, when you're talking about reflux, you don't want to do that right after lunch anyway. Pictures don't look that good when you're talking about that. But the thing is that the association, many people know about it, but haven't put the link together. And really, you can trace it back to as we are developing the esophagus and the upper part of the stomach actually arise from the same germ cell, the cells that form the organs, as the respiratory system. So they actually come from the same cell line. And as they're also physically very close contact, the esophagus, the tube that connects your mouth to your stomach, lies right behind the trachea, which is your main breathing tube, that goes down to the lung. So they're right next to each other in constant contact. And the association that most people think of with esophageal reflux is one where the contents come back up into your mouth, you get that bitter taste, kind of a really acidy taste in your mouth, and you start coughing or you get a little shorter breath. And the thought is that as the contents of the stomach reflux up, we actually aspirate that down into our lungs. We breathe it down into the lungs, and that acid itself can be very irritating to the airway. And it produces a bronchospasm. The airways will narrow down and make you feel tight in the chest and you lose your breath. The thing that's fascinating is when people talk about reflux, they call it heartburn. But in reality, we ought to be calling it lung burn, because reflux affects the lung much more than it affects the heart. We call it heartburn just because of the way it feels when people have really bad reflux. It's almost a pressure or burning sensation they get in their chest as the esophagus goes into spasm because of the acid getting into it. But from a physiologic point, it actually interferes with lung function more than it does with heart function. And that's really what we're going to kind of talk about. I want this to be very informal. If you have any questions, anything you want to bring up, other things that you may have heard, please feel free just to stop, raise your hand, and we'll go through it that way. Now, one of the earlier reports of reflux being associated with lung disease was actually reported in the late 1800s by William Osler, who was a very famous physician. And he noted with his asthma patients, those that ate large meals at night. Now, some people have already talked about this, but in the late 1800s, he made the association of asthma patients eating large meals at night did much worse than asthma patients who ate their large meal at noontime. And he actually advised his patients to have their main meal at noon rather than late at night before they go to bed. So that association's been around since 1880s. Yes, sir?
Squatty, they shut things down midday and take them out and open up late at night and have that meal. Dinner meal, like 8 o'clock at night. Do they have more acid reflux than other countries?
I don't know about that. Like I said, don't study reflux to the degree where I can answer that question for you.
I think they go to bed later though. They eat later, but they go to bed later.
Yes.
Because they nap in the afternoon.
Right.
They have a meal at lunchtime, they go to bed, and then they eat their evening meal late, but they don't go to bed till after midnight. So by the time they've gone to bed, it's all.
Okay.
I thought you were going for the Spanish food.
No.
And they don't eat great big meals either.
Right, no, they don't.
So that association's been around since the late 1800s. And I think when people think about reflux and lung disease, what we think about is that contents coming up, being aspirated down into the lung and causing infections. And certainly it can, it's one of the common causes of pneumonia. And actually over time can lead to bronchiectasis, which is more of a permanent damage that occurs in the lungs due to recurrent infections, and then that in and of itself sets the lung up for recurrent infections. And for a long time, that was what the association was. If somebody had a breathing problem and you were trying to link it to associate with something in the GI tract, unless they gave you a history of food actually coming up into the back of the mouth, there really wasn't much else of a link associated with that. But since about the 1990s, though, there's been a much greater emphasis on the role of reflux and the role of what I would call subclinical reflux, where the person isn't even aware that they're having reflux. So really, when you talk about gastroesophageal reflux, it's a spectrum that can go from no symptoms whatsoever that the patient is aware of or that they would link to a problem with their stomach or with their esophagus, to actually having food and stomach contents coming right back up in the mouth and then choking on it and coughing. And this has led really, I think, to a much better understanding of how intimate the esophagus and the respiratory tract are to each other from the way that they've developed. One of the things that we've noted is that one problem that brings a lot of patients to lung doctors is cough. People have just a chronic cough. They can't explain it. It's irritating. People start to look at you like you're funny because you're coughing and coughing and you just can't stop. You go and you get worked up, they take chest x-rays, do everything. You really can't come up with an etiology for the cough.
Is that cough a phlegmy cough?
Typically it's non-productive, so it's more of a barking, irritating cough.
Dry cough.
And one of the big advances came back in the 1970s when it was recognized that that was actually a variant of asthma. That for some patients with asthma, they don't present with the chest tightness and the wheezing and the can't breathing sensation, but what they have is a cough. It's called cough variant asthma or variant asthma. And with that association, I think lung doctors started to spend a lot more time thinking about esophageal reflux. Okay, because now it was where the presentation was a cough that was being associated with asthma, and then it turns out, as we'll see, that one of the main causes for the asthma attack in that setting is actually due to reflux. So patients who presented with a cough, the large series have shown that over 70% of those patients, the etiology of a chronic non-productive cough, this is a cough lasting greater than about 6 to 8 weeks, was due to reflux. And the treatment of that actually helps calm the cough down and in most cases make it go away. So that was one big step. We realized that the cough can also be a presentation with asthma. And sometimes patients with cough will treat them with a beta agonist like albuterol to help treat the asthma, and the cough would go away. So we said, oh great, well we've got cough associated with asthma. We treat the asthma, the cough goes away. GI doctors were seeing a cough associated with reflux, treat the reflux, it goes away. So then the question became, well, are the two linked? And that's really been the main thrust of research that's been going on up through the 1990s. And one of the things we're starting to understand is that the esophagus actually is able to communicate with the lung, which is kind of fascinating. What happens is, again, not that the food contents comes all the way up and gets aspirated down into the lung and causes the irritation, the bronchospasm, the constriction, the recurrent infections, but rather the esophagus gets irritated. And with that irritation, the esophagus will release a polypeptide, a small protein, that actually causes the airways in the lung to narrow down. This is independent of gastric contents coming up and being aspirated into the lung. It's independent of any type of nerve innervation. There's actually a small particle called a tachykinin, and they call it substance P. I don't know why they call it P, but it's substance P. But they've isolated that as a messenger between the esophagus and the airway. And what they found was taking normal people who were undergoing, getting ready to undergo an EGD, you know, where the GI doctors go down and look at your esophagus. And what they would do is go in and they would instill a little bit of acid in the lower part of the esophagus, way far away from the trachea, so down fairly low. And then they measured pulmonary functions and oxygen saturations. In normal patients, normal people I should say, they actually showed that the airflow dropped. In other words, their airways narrowed down, just like with an asthma attack. Their oxygen saturations also dropped, just from the installation of acid into the esophagus. So it was pretty fascinating. And with animal studies, they went on to actually show that what they feel it is the substance P, this tachykinin, it is this messenger that causes the change in the caliber of the airway and induces the bronchoconstriction or the wheezing that people feel when they're very sensitized to it. So with that, they then started looking at patients who have asthma. It's estimated over 70% of patients with asthma have gastroesophageal reflux. It's a very strong association. And the association for a while was battled back and forth. One of the things we know is some of the medications we use to treat asthma and COPD, like theophylline and albuterol, both of those classes of medications lower the tone of the muscle that helps close off the lower part of your esophagus and help prevent acid from coming back up. Those medications cause those muscles to relax, and as a result, you're more prone to aspiration. So for a while, everybody was pointing a finger at the medications. And the reason why so many people, particularly with asthma, have reflux is because of the medications they have to take. So we were caught in a quandary for a while because those medications are very important for the treatment of asthma. And yet it was also inducing reflux that was causing problems. But as they went on, they were able to show that actually it seems almost to be the opposite way around. And that it's actually the reflux that leads to the generation of the asthma rather than the asthma leading to the generation of the reflux. And what they've been able to find is that the substance P, when they measure it, it's 23 times higher in asthmatics than it is in control, patients who do not have asthma. So for some reason, people who have asthma have a much higher levels of this messenger that goes back and forth between the esophagus and the airway. And they're probably set up for that problem. They get a little bit of reflux, not enough that they even have any symptoms, irritates the esophagus, releases this substance P, and then they go into the bronchoconstriction, presenting either the cough, increasing shortness of breath, or a drop in their oxygen saturations. The other thing is that if you're having a bad spell with asthma or with COPD, where you're struggling to breathe, when you're trying to pull and breathe like that, pulling your air, you generate so much of a negative pressure inside your chest that it actually will pull and lower the sphincter tone and allow reflux to occur more often. So now you can see where you can get into the double whammy. Okay, you get a little bit of reflux, something where you don't even have any symptoms. It causes irritation and bronchoconstriction, narrowing of your airways, makes it harder for you to breathe, you're breathing harder, and as you pull harder to breathe, you're actually causing worse reflux, which irritates, and you get into this cycle. And it can become very progressive over time, or it can become self-sustaining, where you just have recurrent bouts of COPD, one after another. And as a pulmonologist, I'll try all kinds of medications. You know, I can get you feeling better for a little while, put you on some prednisone or steroids, but then as we take you back off, you're back into trouble again. And one thing we're starting to understand now is the role of reflux, that subclinical reflux, in this whole cycle, which is why the use of anti-reflux medications, such as H2 blockers like ranitidine or PPIs that you see in like Ilosec and things like that, have become so important. And as a pulmonologist now, that's probably the second most common class of medications I prescribe besides lung medications, are medications for reflux.
And do you feel the over-the-counter are just as good as anything?
The ones you get over the counter, the Prilosec and that, the purple,
Right,
yeah.
just generic names,
The generic-
Walgreens, blah, blah.
The generic are as equivalent as the ones that are prescribed. I can't say anything about flaxseed, but it's definitely something to try. I mean,
Right, I take it.
Is there a time when I remember?
I take fish oil, makes me burp.
Prilosec?
I burp fish.
the ones that suppress the acid secretion you're referring to, that's always been a debate as to how long people can be on them. I think the important thing with the irritation that occurs in the lung is if you can shut down the reflux, get control of either the asthma or the COPD, then you can start backing down a little bit on your anti-reflux medication.
Are esophageal spasms the ones that feel like a heart attack? Are they, is there anything you can do with those besides taking the,
The question is about esophageal spasm, which is really what causes what most people talk to about heartburn, that horrible sensation you get in your chest. The esophagus is a muscle, it's a tube that's all muscle. When it gets irritated, it goes into spasm and it cramps. And as far as the way you treat that is to try to suppress the reflux, get rid of the acid secretion that's coming up into the esophagus. And it's the age-old things, keeping the head of bed elevated, don't eating large things at night, staying away from certain foods that you know can trigger it. And it's not hot, spicy foods. It'll vary from person to person what type of food gives them their reflux. Chocolate, caffeine, things like that will definitely raise your chance of getting reflux, so you want to stay away from those. But usually keeping the head of the bed elevated at night makes a big difference as well. But the length of time that people can be treated, particularly with high-dose PPIs, like Prilosec, are what's kind of unknown right now. The thing that's interesting is once we made that leap and understood the relationship of reflux, let's say, to asthma, what we started to realize is that an asthmatic who has reflux doesn't usually respond to the standard dose of Prilosec, let's say, using that as an example. And then about 40 to 50% of asthmatics actually need to go to a double dose in order to control their symptoms. And until you can get those symptoms under control, you're really fighting a losing battle trying to control the asthma, trying to get them off of their steroids, you're trying to cut down on their use of a nebulizer to get them under better control. Now, a lot of the research has been done with asthma, but the type of changes we're talking about will affect patients with COPD as well. Because you already have chronic narrowing of the airways, and your airways already start out being very twitchy and reactive to any type of irritation. And again, if somebody who's having subclinical reflux, where they don't have the classic signs and symptoms of what people call heartburn, many times that's overlooked. And as a result, we pile on all kinds of other medications without trying to go after the reflux. And so typically now what we'll do is in somebody with asthma or somebody's having a very difficult to control asthma, is we start them out PPI empirically. Just go ahead and start them on the drug and see how the medication is working. If it results in a benefit to their breathing, then we say, okay, they probably have subclinical reflux and we need to keep them on this medication. If they're not showing benefit, then what we typically do, we'll double the dose, go to a higher dose of the medication like Prilosec, and to see if maybe they're in that 40 to 50% group that needs a much higher dose to control their acid secretion. And then finally, the last thing is to actually then refer to a GI doctor. And actually there, what they'll do is they can put a small probe down into the esophagus that sits there for 24 hours, and it measures if any acid's getting up into the esophagus. And so they can really determine, are you actually having this reflux that's subclinical? And it's very important because if that's what's causing the whole breathing problem, unless that's addressed, all we're doing is pouring more and more medications on board when the actual stimulus to what's making things worse is kind of unrecognized. The only other thing that your doctors may refer you to is an ENT doctor, but sometimes what they can do is just take a quick peek at your vocal cords. And people that have more gross type of reflux, where the acid comes up higher, their vocal cords will actually be swollen and red, and that's usually a classic sign that somebody's having reflux. Now you think, well, wait a minute, if somebody's having stuff coming that high up in their throat, they should be aware of it. It's amazing how many people have no symptoms that you would recognize or that they recognize of heartburn, or reflux. So somebody with a chronic cough, that's one of the things we'll be thinking about. Somebody who has difficult to control asthma, somebody who has recurrent exacerbations of their COPD. Those are all the things that we'll be tracking down. Now, it is important to remember that some of your medications will also predispose you to reflux. And you may find as your physicians are changing your medications, all of a sudden you start noticing, oh, God, what is that, you know? And what you're probably experiencing is that because the effect of the medications coupled with your disease, that you're starting to get some reflux. The reason it's important not just to pass that by is, again, if you're refluxing, okay, chances are that substance P is being released and is worsening your lung function. So it's important if you feel anything like that, when they change the medications, make sure you let your doctors know about it so they can track it down. Yes, ma'am?
Speaking of the vocal cord thing, I went through a series of testing, and I have Rinke's edema, which is a vocal cord disease. It's the mucus buildup and the edema in the vocal cords. So that's a discovery too.
Yeah, and that's what I'm saying. There's different pathways that your doctors may go down to try to track this down. Some may, like I do, I just go ahead and start the medication because it's easier, and to be honest with you, it's cheaper than going through all these other pathways. If that doesn't work, then it's important that you still go the next step further, which would either be a GI doctor, the gastroenterologist getting a look to see if they can find any evidence of reflux, or ENT doing an examination. The ENT examination is quick, and that's what's nice about it. Turn it up.
Long-term acid reflux is the acid that gets into your lung, turning and scarring,
Well,
causing the pulmonary fibrosis, maybe?
I have not found a link between reflux and interstitial fibrosis per se. Certainly the reflux, when it causes the release of this substance P, causes inflammatory changes in the lung. Okay, there's the neutrophil and the eosinophil, two cells that are believed involved with asthma and COPD, are upregulated because of this substance P. There's more of them there. They're kind of angrier. They're there to fight something. And to be honest with you, at that time, there's nothing there for them to fight. So it's like a bunch of kids on Friday night, they're hanging out in the street corner. They got nothing better to do. Pretty soon, something's going to break out. And so, yeah, over time, the recurrent exposure to this can create a chronic inflammatory state, which can then lead to the development of COPD, and I can't say if it would lead to interstitial fibrosis or not, but certainly the inflammation is going to be there. So it's very important to try to get that tracked down. The other thing to understand, one other disease process, I didn't see anybody here who claim they suffer from it, is patients with sleep apnea. Okay. Don't see anybody falling asleep. So everybody's got that little secret that they keep. But with sleep apnea, the interesting thing with sleep apnea, again, is that they go hand in hand. Okay? If you reflux, particularly if it comes fairly high up, you can get swelling and edema in the soft tissue in the back of the throat, which then sets you up to obstruct at night when you're breathing. You kind of choke off. As you choke off, if you have obstructive sleep apnea and you have that apneic spell, okay, where you're blocked and you're trying to breathe, you're still sleeping. But again, you're pulling such great pressure changes in your chest that you set yourself up for reflux. And so as you reflux, it's going to cause, again, this whole cascade of things to occur. So one of the things that's exciting is, since we've been able to now track down this substance P, okay, is there's actually several drugs in the work now that are antagonists to substance P. And so hopefully they'll end up being a new treatment, particularly for asthma, but also for other patients with lung disease who have bronchoconstriction or irritation because of the reflux. And I think once that occurs, hopefully we won't find out. A lot of problems when we find this stuff is that substance P has to be there for a reason. All right? I mean, it just doesn't make sense when we were created that this substance would kind of show up with no purpose whatsoever other than to make our life worse. So the thing you get worried about is if you come up then with a treatment that blocks it, then what do we set ourselves up for? Same thing like you were kind of talking about earlier with the medications for acid production. There's a reason why we have acid in our stomach. It's supposed to be there. And obviously in some people it causes problems, so we shut down the production. Well, what's the long-range problem if we shut down the production of the acid? And that's one thing that everybody's still looking at. All of our medications that we do are always blocking something that's there, and then it's always a matter of finding out what's the long-term effect. And that's why you'll hear reports of medications come out that everybody's very excited about, then 4 or 5 later it's off the block. It just disappears because it turns out, yeah, it did this, which we thought was going to be good, but then it did this, which turned out to be bad.
Can that cause pernicious anemia?
Pernicious anemia is one of the things that can be associated with low acid production in the stomach because the vitamin, I'm getting way off my list, I think it's B6, it needs an acid to allow it to be absorbed. There's a cofactor that needs to be present. I know that's one of the concerns, but I'm not sure if it's been linked. Yes?
What about ibuprofen and acid reflux? Because you know, I've got stomach ulcers and I use an ibuprofen, but it's so beneficial that sometimes I just take, I just take it just once because it really works and it's very helpful.
Yeah. The issue with the non-steroidals like ibuprofen is it lowers the mucin production in the lining of the stomach. And when you think that the pH in your stomach is about 1, which is very equivalent to hydrochloric acid, I mean, it's very acidic. What the stomach does to protect itself, it creates this mucus that helps buffer it so that the cells aren't destroyed by the acid. What happens with the non-steroidals is they cut down on the production of that mucus. So now the acid can get to the lining of the stomach and cause the ulcers. Okay? So that's why they say if you have trouble with ulcers, you shouldn't use ibuprofen for those reasons, or even aspirin. Those type of things can set you up for worse bleeding because of that. I think the secret for something like that is that you don't want to be on a chronic. Anecdotally, take it every once in a while, so probably not. Somebody back there had a question?
Yeah. I believe in
I think over there.
But tell me this, do you think that they will come anytime soon, that the medications we are on will start causing so many side effects for other things in your body?
No.
Boy, I would like to think so. I think we're on that pathway, but when you say anytime soon, I don't think we're there yet. The reason is because one of the things we're starting to do now is focus our medication based on the genome of the patient. It turns out that it's how our bodies are put together is how we react to a lot of the medications. And in some, you can actually predict what patients will do well or poorly with a certain type of medication. So that is just in its infancy. It's just getting started. But certainly in the future, I'm not saying the near future, but in the future, when you go first time to see the doctor, they may do a buccal smear where they take a couple of cells off your lining of your mouth and find out what your deep DNA looks like. And they can run it and say, okay, you are going to do really well with a PPI, you're going to do horrible with ibuprofen. They're going to be able to do that. Not with everything, but I think as we get a better understanding. But that's way down the line, unfortunately.
You'll be dead.
What do you think about apple cider vinegar tablets? Do you have any input on that? Well, I've got a friend that takes them every day. She has no more acid reflux.
Like I said, I never argue with anything that the patient tells me works, okay? Because there's a lot of things out there that we don't understand. There's a lot of medication treatments, a lot of illness treatments been handed down through cultures and through families that we still don't understand.
Try it, if it works, fine. Huh?
Yeah, I say if it works and it's not causing any trouble, even if I can't explain why it works, I can't argue with it, if you're doing better on it. But I don't know, anything about apple cider tablets?
Yes, apple cider vinegar tablets. She takes them every day, and there's no acid reflux.
Now, I know with vinegar itself,
Yeah,
there's a
and I
lot of
drink-
claims for health benefits.
I drink vinegar and
That
water.
doctor with that fellow with the vinegar, he was in jail. He did components of this vinegar stuff. You know, but he went in jail.
And that's what I'm saying, is you can take something that has some truth to it, and then you push it out, and you can cause, obviously, a lot of misunderstanding. Sir?
And severe to the point that literally it felt like it was taking the enamel off of my teeth.
Say what? Say that again?
The reflux.
The reflux was to the point that it actually felt like the acid was taking the enamel off of my teeth.
Wow.
And I was on Nexium for about 7 years. I tried to do a shot of vinegar. I'd rather do a shot of scotch, to be honest. I weaned myself off of it. I found when I stopped taking it, apparently I was addicted. I mean, my body was nuts when I stopped taking it.
Yeah, there's research that says that it has some side effects when you try to come
What
off.
was that you were taking?
Nexium.
Oh, Nexium. Oh.
And gentleman spoke about losing weight. I lost about 20, 25 pounds. My diet is different.
Yeah.
I have not had acid reflux to amount to anything for months. I do still, and I know why I do it, I shouldn't eat this. And I've gotten so I'm a little proactive there, but it can be done. And I also found I sleep on my right side. That tends to be a trigger also. And if I start having acid reflux, I get off of my right side. And it will calm me down.
That side has a lot to do with a lot of things. You're supposed to be on your left side at all times.
No wonder I'm messed up.
Yeah, right.
I'm flat in the back.
I am too, but one of the research has found out, like, you feel like you're gonna throw up. On your right side, you're gonna throw up. On your left side, you're just about
It depends, because it depends what their problem is. If you sleep on the right side, you actually aid the stomach in draining, okay, because it empties to the right side and goes out. So if you're in bed with a big bloated stomach, sometimes it's better to lie on your right side because it allows it to go out.
But the biggest change I made was reducing weight and diet.
And again, a lot of that is, you know, we talked again about sleep apnea. A lot of people raise their hand. Well, I would bet those people who didn't raise your hand, you got tested, quite a few of you probably test positive. A lot of people suffer from sleep apnea and aren't aware of it. And losing weight is one of the most effective things you can do to help cut down on the severity and the degree of your sleep apnea that you get. And again, if you're tugging because of that, you're going to get more reflux. And I said, you come up with a list of the foods you know are going to make it worse for you. On the ads, it's always, you know, the pepperoni pizzas and the hot, you know, hot spicy food, but that association is pretty wishy-washy.
It can be bland stuff also.
Exactly. I mean,
there are certain things that I eat that I know should not have caused it, but it does.
What are they?
It's just some types of gravies sometimes. It doesn't matter. It's something very bland. And that's all I've eaten. But then I'll have a whole burst of reflux.
ice cream late at night, any dairy products.
anything with fat in it. And again, eating a large meal before you go to bed is probably the worst thing you can do. You know, that late night snack you have before you hit the sack, or if you're a late eater for some reason, you know, you're going out for dinner and you usually eat at 6, but now you're eating at 9, okay, chances are that evening you're probably going to have some problems with it. But again, that's the one that people are aware of. A lot of people, what they may wake up with is a cough, you know, and what they're getting is that subclinical type of reflux that's causing the irritation. Let's say that association now has gotten so strong that anybody who comes to our clinic with cough, if the chest x-ray and everything is normal, we pretty much put them on a PPI right off the bat. Because trying to track down a cough, I mean, for the person who's suffering from it, it's horrible. And as a healthcare provider, trying to figure out where it's coming from. You know, you're doing test after test and you keep coming back negative and they still have the cough and you're loading them up with all these medications. And people start getting really frustrated, and it turns out that in many cases, it's just a simple case of reflux. And you can treat pretty easily. Yes, ma'am.
Go to an ENT doctor. I have a lot of mucus in my throat, and it's just constantly there. Do they have to, don't they numb your throat? Would I go crazy?
No. What they do is they spray in a little bit of medication. It's like a lidocaine, but it's just a spray. And it just numbs it up. Depends, it may take a peek through your nose. They spray it in the nose as well. It's a little fiber optic scope. It's very thin. And it's just something that they take a peek with. It's real straight.
I'm scared one day gonna numb my throat, I'm gonna go crazy.
No, it'll be fine.
Yeah, no, they actually get it numbed up very well.
It's not a whole lot different than bronchoscopy.
It's much simpler than a bronch.
Take a Valium.
I've had these bronchs called, but it's sprays that
The answer to everything.
long Q-tips way back in here.
Stop.
You'll be fine.
And we got some questions up here.
I have two questions. When you have acid reflux, I understand that the gallbladder is the place where the acid is stored and it releases to a certain amount.
It's a different type of acid. There's bile acids that are stored in the gallbladder. That classically comes out past the stomach. So
that should have nothing to do.
Well, it turns out bile does, because in some people with bad reflux, bile actually gets into the stomach, and that irritates the stomach and makes reflux. So you actually can have bile come back up. We actually see that in patients where we drop NG tubes in, like when we're feeding them or something, a tube that sits in the stomach. And before we give any feeding, we always pull back. And a lot of times when you pull back, you'll get bile back. And that's when bile's gotten into the stomach. So it does happen. But the acid that he's talking about is hydrochloric acid that's made by the stomach itself.
Because I've got acid reflux and I was blaming it on the gallbladder.
Well, it can make it worse. As I said, there are people where bile does come back into the stomach, and that just makes it even worse.
That second part is I've got idiopathic pulmonary fibrosis, and what you have on COPD and the nebulizers and so forth that helps that doesn't help me at all, because I've lost about 50% at this stage. So when you think about that, there's nothing in that medications, or they've tried them all, so it doesn't work.
Yeah. Obviously the difference between COPD and fibrosis is two different illnesses that you're talking about. And they affect the lungs in a different manner. I know you got a big conference coming up on interstitial fibrosis, so you'll hear a lot more about that. I guess it's next month.
It's December 3rd.
But the thing to remember with fibrosis is more of a scarring process. With COPD and asthma, it's a muscular process where they get bronchoconstriction. The airways actually clamp down and narrow. So a lot of the medications work better for that. But people with interstitial fibrosis can still get that narrowing. Like if you get a viral illness, okay, like a bad case of the flu, you may actually get more short of breath on top of that because of the irritation that the virus causes. If you were to reflux, it might make you get a little more short-winded, but it's a different mechanism, definitely different.
Thank you.
Yes.
Don't you have acid on your stomach normally?
Yeah. Yeah. The stomach's got to be there to take care of that stuff you eat. You think about the stuff we put in here, you know? And that's always one of the concerns with going with long-term antacid therapy, is that we're supposed to have that acid there, and now we don't have the acid there. What does that do with our new nutritional status? What does it do with the vitamins that need the acid in order for them to become active?
Well, I take Osmo pill, because I've got no need for an Osmo pill, and I've taken that steady for years, and that stops all your acid.
What type of pill? I'm sorry.
Osmo Pro.
Omeprazole.
That's better.
Generic for what?
Generic, yeah.
That's all that is, a generic.
Yeah.
I couldn't tell you what the brand name is because I work at the VA. We don't do brand names. So you guys probably know the brand name is better than I do, but that's a PPI as well. It's in the same class.
it doesn't bother me otherwise. If I stop that 2 or 3 days trying to get off,
You can feel it. But again, a lot of things, if you do weight loss, if you change your diet patterns, it may help, but some people are going to have to be on it. There's no getting around it. Yes, ma'am.
Is your take on the product Tums?
Tum-to-tum-tums. If it works, great. Okay? I mean, it's a fairly weak antacid. It has calcium in it. Good for you. It tastes better than a lot of the other medications that you may get. It's, you know, I don't think it's going to harm you if it works well to control your symptoms. It's a heck of a lot cheaper than the other stuff. Plus, it has calcium, which is good.
So that kind of leads to my other question. Has there been any research on PPIs and osteoporosis?
Okay.
I'm sure there has been, to be honest with you. I'm not aware of what it would be.
Because it's just a sort of, you know, one of these lawyers' adverts on the TV. If you've taken Nexium,
well, the problem
now you have osteoporosis, call us.
And that's the problem is when you come into it, you know, you figure because it's changing the pH in the stomach, it probably alters your ability to absorb calcium. Because calcium has to be in
So if you take calcium at the same time,
and that's what I did. And I think that's what people have to understand is, again, we talked about how the medications have the good effects and have the adverse effects.
Right.
But sometimes if we know what those are, we can counter them.
Right.
Yeah.
But unfortunately, we add another pack of pills.
Yeah, exactly.
Yes, ma'am.
Advair eats your calcium. Advair.
I'm on that too.
Yes, the steroids.
That's because of steroids in it.
Yep.
Yeah.
Well, any steroid preparation.
You've got to take calcium.
The Symbicort as well. I mean, they actually do set you up for osteoporosis. It
Yes.
affects women much more than it affects men. And if you're on the higher doses of Advair or of Symbicort, you have to worry about that as well. Pretty much anybody that's on long-term steroids should get their bone density checked to make sure they're staying on top. Yes, ma'am. Oh, yes, ma'am.
What can you share with me about us with pulmonary hypertension? I only heard one other person mention that they had it, and how would we exercise? I found myself that I could walk 2 or 3 steps by the end of the breath. I used to be in rehab, but I don't know how that would
Well, as far as the last point, rehab, that your doctor has to tailor that for you. So I'm not sure how severe it is. The pulmonary hypertension, remember, I don't know if you guys may not know this, but the heart has 2 chambers. It has a right side and a left side. The lung is in between. Now, the one type of hypertension we all know about is what we call systemic hypertension, and that's what the left heart pumps against. Pulmonary hypertension is when the pressures through the lung bed are elevated. So it makes the right heart have to pump harder in order to move the blood through the lung bed. There's many different causes for pulmonary hypertension. The most common cause of pulmonary hypertension is when the left ventricle isn't pumping as well. So people with heart failure or people who have valve problems, because the fluid backs up, so now it forces the right heart to pump harder. But there's also many disease processes that are independent of heart disease that can cause pulmonary hypertension. The lung diseases that will cause it would be something like COPD, interstitial fibrosis, sarcoidosis, any disease that causes destruction of lung tissue will in time destroy the vascular bed, the blood vessels. Now you still have to move the same amount of blood through that lung, but now you have fewer vessels for it to go through. And as a result, the pressure starts going up. And the problem with that is the right heart has to pump harder now. And just like the left heart can fail, like people who have long-standing hypertension, they can develop heart failure because of that. You can actually develop a right-sided heart failure called cor pulmonale, okay, which means lung heart, where the right side is the one that's failing, and it's because of the lung disease. What you do there is you try to correct the factors that are causing it. More common things are hypoxemia, which is why oxygen therapy is very effective in trying to control the degree of pulmonary hypertension. And then once they determine the severity of it, there are medications that are available that in some classes of hypertension can be very effective. So I'm sure your doctors are working through that, but as far as your exercise protocol, you want to make sure that they're guiding that for you. Because if you're overexerting yourself and your right heart can't keep up the work, you're going to go into failure because of that. Yes, sir.
Yeah, quickly, it's 3 o'clock, but people with asbestosis, are they more susceptible to having more and more problems like COPD coming on more? Is that part of it?
With asbestosis, that's going to cause more of a scarring process in the lungs, but you put that on top of obstructive lung disease like COPD, and it's going to flare up. Both of those processes tend to be chronic and slowly progressive. So over time, you're going to lose a little bit more function and a little bit more function. And again, I can't stress it strongly enough, make sure you get your flu shot, okay? It's very important that you get that. Any type of lung disease, any type of infection in the lungs can only accelerate what's going on in here. You want to try to stay as healthy as possible. Remember, the flu shot doesn't prevent the flu, it lessens your chance and lowers the severity of it. The best advice I can give you, I know a lot of people are here talking about having grandchildren, and okay, if they got a snotty nose, runny eyes, stay away from them, okay? Wash your hands.
Could you talk a little bit about the relationship between the autoimmune system and interstitial lung diseases?
Wow.
Like things like Raynaud's, Meniere's disease, rheumatoid arthritis. Sometimes these can
lead. A lot of the interstitial lung diseases where we know what the cause of it is, and a lot of times patients with interstitial fibrosis, we can't really come up with a cause because by the time we see the patient, it's so far down the line that whatever was triggering it in the first place may have disappeared. But autoimmune processes are definitely associated with interstitial fibrosis, lupus, rheumatoid arthritis, anything like that. And what happens is with all of those illnesses, what's happening is the body attacks itself. With rheumatoid
You go home?
I like to sit right here.
Carol and Lance. It takes a while when you get sick.